Evidence-based practice, part 6, the culture of healthcare. So welcome to the culture of healthcare. This is evidence-based practice. Again, this is part 6 of our series. In this lesson, we're going to continue exploring the culture of healthcare, what it means to work in health settings day to day. We'll look at job expectations, how care is organized within different practice environments, and the critical role of privacy laws. We'll also examine the professional and ethical issues that shape practice across the health professions, and by the end of this session, you'll have a deeper understanding of how workplace culture intersects with evidence based practice to influence both clinical decision making and patient outcomes. So let's get started. Objectives for evidence based practice in clinical engineering. So, we are going to discuss the benefits and limitations to summarizing evidence. And engineers often rely on systematic reviews, meta analysis, and health technology assessments when advising hospitals on equipment purchases or upgrades. These summaries provide a high level view of safety and effectiveness. However, they may overlook local factors like staff expertise, infrastructure, or patient demographics, areas where engineers can provide critical context before decisions are made. Summarizing evidence. The idea behind summarizing evidence is that for many tests and treatments, there are multiple studies, such that one study doesn't tell the whole story. One study may contradict others, or studies may complement each other, and taken together make a much stronger case. For this reason, there's a growing trend toward what are called systematic reviews or evidence reports that aim to bring all the evidence on a given test or treatment together. In this lecture, we're turning to the concept of summarizing evidence. For many tests, devices, and treatments, there isn't just one study. There are often multiple studies, each adding a piece of the puzzle. Sometimes they agree, other times one study may contradict another. That's why looking at a single study rarely gives the full picture. To address this, healthcare has increasingly moved toward systematic reviews and evidence reports, structured efforts to put all the available research on a test or treatment together. So, for clinical engineers and healthcare providers, this matters because decisions about adopting or maintaining technologies, as well as recommending treatments, should be guided by the totality of evidence, not a single trial or anecdote. Think of the Haynes Forest model. At its foundation are clinical studies. Above that, we have synthesis and synopsis, tools that combine evidence and present it in a form that's easier for clinicians to digest and apply in practice. So, by summarizing evidence, it isn't just a matter of stacking studies side by side. There are methodological challenges. That's a tough word to say, methodological challenges, which is a challenge in itself, where you have different studies that may use different designs, they measure different outcomes or include different patient populations. And recently, a supplement to the Annals of Internal Medicine emphasized that systematic reviews require rigorous methodology, careful inclusion criteria, transparent research strategies, and critical appraisal to ensure that summary truly reflects the state of knowledge. If we're going to create a systematic review, what are the steps? Guyot, in his textbook on evidence based medicine, lays out a structured process, and it begins with the most important step, defining the clinical question. That's kind of similar to engineering, where we're trying to identify the problem, which is the defining step. And that question needs to specify the population, intervention, comparison, and outcome, and it's often abbreviated as PICO, P-I-C-O. And once the question is clear, the next step is a literature search. But this isn't just typing a few keywords into Medline. A systematic review requires what's called a comprehensive structured search strategy across multiple information sources, casting a wide net to capture every potentially relevant study. From that broad search, we apply inclusion and exclusion criteria to identify which studies truly address our questions, because reproducibility is key, and these decisions are often made by more than one reviewer. That ensures you have consistency in how articles are judged. And then next, the chosen studies are examined in detail. So we abstract the data, carefully recording what each study contributes. If the data allow, we can perform a meta-analysis, pulling results to give a clearer picture of effect. Along the way, we assess heterogeneity, which says whether different studies point in the same direction or show conflicting results. And then finally, we must also look for bias, including publication bias, which occurs when studies with positive results are more likely to be published than those with negative or inconclusive findings. And for both clinicians and clinical engineers, this process is vital. Whether the question is about the effectiveness of a new drug, the reliability of an infusion pump, or the long term outcomes of an imaging modality, a systematic review provides the most rigorous, trustworthy synthesis of evidence that's available. So, what kind of analysis do we perform in a systematic review? Often, systematic reviews use a technique called meta-analysis. And in meta-analysis, the result of multiple studies, when they're appropriately similar, are combined. For example, if several studies have examined the same treatment in the same disease and patient population, it makes sense to pool them. By combining studies, we gain statistical power. Larger sample sizes makes it easier to detect meaningful differences and achieve statistical significance. In this way, a meta-analysis can give us a clearer, stronger answer than any single study on its own. But here's the catch. You don't have to, and sometimes we shouldn't do a meta-analysis. If the studies are too heterogeneous, different patient groups, different clinical settings, different outcome measures, then pooling the results would be misleading. Take telemedicine, for example. Suppose one study looks at dermatology, another radiology, and another psychiatry. Each tells us something valuable, but the studies are so different that combining them would be inappropriate. At best, we might pull data from a few similar studies within some specific specialty, but not across the board. When we do conduct the meta-analysis, we use a summary measure to capture the treatment effect. Common measures include the odds ratio or the weighted mean difference. These are tools that allow us to express the overall effect across studies. And the key point is meta-analysis is powerful, but only when studies are sufficiently similar. Otherwise, the summary could obscure more than it reveals. When we interpret systematic reviews and meta-analysis, we often rely on summary statistics. Two of the most common are the odds ratio and the weighted mean difference, of which I mentioned earlier. And the odds ratio is used for binary events, things that either happen or don't. Think of outcomes like death, heart attack, stroke, high blood pressure, kidney disease, diabetes, or the reoccurrence of cancer. And here's how this works. So, an odds ratio less than 1 suggests that the treatment reduces the chance of the event, and that means there's a treatment benefit. This is the approach used by the Cochrane Collaboration, one of the leading groups in evidence synthesis. And importantly, we also look at the confidence interval. If it does not cross the odds ratio equals 1 line, then the results are considered statistically significant. From odds ratios, we can even calculate the number needed to treat, which translates the statistics into practical real world meaning. The second common statistic is the weighted mean difference, which is used for numeric measurements like blood pressure or blood sugar levels. A value less than 0 suggests a benefit for the treatment, and a value greater than 0 suggests the control was more effective. So, just as with the odds ratio, if the confidence interval crosses 0, the result isn't statistically significant. And if it does not cross 0, then the finding is statistically significant. So, in short, odds ratio will help us interpret yes or no outcomes. Weighted mean difference, this helps us interpret continuous measurements. So, in both cases, confidence intervals tells us whether the evidence is strong enough to be considered statistically meaningful. Examples of systematic reviews. So let's look at cardiac risk factors as our example. Let's look at some real world examples of systematic reviews, especially in the area of treating cardiac risk factors. So in the early 2000s, a group of meta-analyses looked at different strategies for lowering cholesterol and homocysteine levels, whether through statin drugs, other types of medications, or lifestyle interventions like diet. The combined findings were powerful. They led some researchers to propose creating a poly pill, a single pill that would contain six medications, so a statin, three blood pressure lowering drugs at half their standard dosage, beta blocker, folic acid, and aspirin. And the idea was pretty bold. If widely adopted, such a pill could potentially reduce cardiovascular disease in Western countries by up to 80%. Not surprisingly, this proposal sparked debate. Many experts argued that we couldn't assume such a dramatic benefit without proper testing, and that the polypill itself would need to be studied in a randomized controlled trial. The discussion became so lively that it filled the pages of the British Medical Journal and other outlets with correspondence and counter arguments. At the same time, others suggested a more natural alternative to the so-called polypill, right, or the polymeal, since there was so much in there. This approach combined everyday foods like wine, fish, dark chocolate, fruits, and vegetables, and then spices like garlic and nuts like almonds. And so far, this sounds great to me. Um, so all of this was meant to be natural, so assuming natural then safe, but also tasty, because just saying it sounds tasty, and still effective at reducing cardiac risk. So, you know, the polypill or the diet. And what happened to the polypill itself? It was actually developed and it was tested. There were initial clinical trials in India starting around 2009 or in 2009 that showed promising results. There was a follow-up study in 2012 that confirmed that the pill could lower both blood pressure and cholesterol levels simultaneously. And these examples show how systematic reviews and meta-analysis don't just summarize evidence, they can inspire entirely new ideas for prevention and treatment, sometimes sparking global debate along the way. And that is actually good because, again, not just looking at the healthcare culture, but looking at the populations that are being treated, looking at the cultures of the patients themselves also plays a role into uh, providing healthcare. An important player in the world of systematic reviews, again, is the Cochrane collaboration. This is an international initiative dedicated to preparing and maintaining systematic reviews of the effects of healthcare interventions. Its main focus is on interventions, so treatments, therapies, and strategies for improving health outcomes. It generally does not focus on diagnosis or harm unless those issues arise in the context of an intervention or a prognosis. So the Cochrane collaboration has also become a global standard for high quality evidence. Its reviews are rigorous, they're transparent, and continuously updated as new research emerges. So, for clinicians and clinical engineers and healthcare providers, Cochrane reviews are often the most trusted source when evaluating whether an intervention truly works. And best of all, the information is accessible. The abstracts of all of Cochrane's reviews, they're freely available at www.cochrane.org. And this makes it a valuable resource for evidence-based practice across the world or worldwide. The Cochrane Database of Systematic Reviews. So the main product of the Cochrane collaboration is the Cochrane Database of Systematic Reviews. Both the collaboration and the database are named after Archie Cochrane. He was a British physician. In 1972, he made a powerful observation, and it's surely a great criticism of our profession that we've not organized a critical summary by specialty or subspecialty adapted periodically of all relevant randomized control trials. Pretty powerful stuff that he said there. The Cochrane database of systematic reviews is the realization of that vision. It represents an organized, continually updated collection of the best available evidence from random controlled trials. So it makes it accessible to healthcare professionals worldwide. So, remarkably, the Cochrane collaboration has been built largely as a volunteer effort. In just about a decade, it produced around 2,000 systematic reviews, and that's an impressive achievement, but it still represents only a fraction of medicine. And that raises an important question. How sustainable will the Cochrane collaboration and its database be over time? So, as the body of medical research grows, keeping reviews comprehensive, updated, and accessible remains a challenge. Still, the Cochrane database has set a high standard for evidence-based practice. So, carrying forward what Archie Cochrane's call for organized critical summaries of medical research is on the verge. Yeah. So the Cochrane review is a type of systematic review designed to provide the highest quality synthesis of evidence. Each review begins with a clear statement of the clinical problem or the question. The evidence is then gathered, usually through a comprehensive literature search, while the vast majority of reviews rely on experimental data and a small number have included non experimental evidence, though that practice is somewhat controversial. The review makes its inclusion and exclusion criteria explicit so readers can see exactly which studies were considered and why, and the results are then presented in a variety of ways, both tables and graphs, and this makes the findings just easy to interpret. If a meta-analysis is part of that review, those results are clearly described, including pooled data and measures of effect. And finally, the authors draw conclusions based on the weight of the evidence. One of the most distinctive aspects of a Cochrane review is that it's designed to be a dynamic, living document. So, unlike a journal article that might be updated only every few years, Cochrane reviews are stored in an online collection of databases, and each one includes the date of its last substantive update. And the goal is continuous revision, ensuring that as new evidence emerges, the review evolves with it. In this way, Cochrane reviews serve as a constantly updated resource, and they help clinicians, healthcare providers, and even clinical engineers to make decisions based on the most current and trustworthy evidence for those who actually go out of their way to utilize it. When it comes to summarizing evidence, there are many resources available to clinicians, healthcare providers, and clinical engineers. We mentioned synthesis. Two of the most widely used are the Cochrane Database of Systematic Reviews, which provides rigorous, continuously updated reviews of healthcare interventions. There's PubMed Health, that's from the U.S. National Library of Medicine, which offers high quality evidence synthesis on a range of clinical questions. And you'll have to check check me on that if PubMed Health is still available. For synopsis, there are several excellent resources. So we have clinical evidence, which describes itself as an evidence formulary. It draws on Cochrane reviews, other systematic reviews, and individual studies to summarize what we know about treatments and outcomes. There's InfoPoems, which stands for Patient Oriented Evidence That Matters. That's the poem in the InfoPoems. And this resource focuses on evidence that is not just scientifically sound, but also directly relevant to patient care. We also have something called PIER, P-I-E-R, the Physicians Information and Education Resource from the American College of Physicians, which provides structured summaries of evidence to guide clinical decision making. And together, these resources move us beyond individual studies and toward synthesized practical evidence that clinicians and clinical engineers can use at the point of care. Limitations of systematic reviews and meta-analysis. So, while systematic reviews and meta-analysis are powerful tools, they're not without their limitations. Some experts, like epidemiologist Alvin Feinstein, excuse me, have argued that meta-analysis can be misleading. He famously referred to it as statistical alchemy. His concern was that by pooling studies with different methods, populations, or designs, we may create the illusion of precision while actually compounding uncertainty. In fact, we sometimes see different meta analysis on the same topic using many of the same studies, but reaching different conclusions. And that variation often reflects methodological choices, what was included, how data was pooled, or how outcomes were defined. There's also the issue of the so called half life of knowledge. One study examined how quickly scientific conclusions get overturned. Interestingly, in the field of liver disease, findings from meta analysis had the shortest half life, meaning they were more quickly overturned than findings from randomized controlled trials. And finally, we must remember the problem of publication bias. Systematic reviews rely on the body of published evidence, but if studies with positive results are more likely to be published than those with negative or inconclusive findings, then systematic reviews will be skewed. This bias can lead us to overestimate benefits or underestimate harms, drawing incorrect conclusions. And so, there's a key takeaway here that systematic reviews and meta analysis are invaluable, but like any tool, they must be used critically and cautiously with an eye toward their limitations. So, this concludes part six of our series on evidence based practice. Again, in this lecture, we've seen that when it comes to medical tests and treatments, there's no single study that tells the whole story. To get the most accurate picture, we need to look across multiple studies, sometimes complementary, sometimes contradictory. That need has driven the development of systematic reviews and evidence reports, which bring all the evidence together in a structured way. As the Haynes Forest model reminds you, synthesis combine primary data into stronger foundation of knowledge. And synopsis take that knowledge and make it accessible, practical, and highly summarized for clinicians and healthcare providers. And together, these tools ensure that decisions in healthcare and in clinical engineering are grounded in the best available evidence, not just isolated findings. With that, I want to thank you again for listening to this session, for sticking all the way through it. And if you've been listening to the evidence based medicine part of this series, we have one more to go. So I will see you in the last part, which is past part seven.